Okay, can you still see my slide?
Yes, not slides.
Okay,
Now
sorry.
we can see the entire
Yeah, okay.
screen.
Okay, sorry, 1 second.
You will have to minimize this, then I think you
Yeah,
can see.
okay.
Yeah,
Can
now
you
we
see
can
it
see.
now?
Yeah, we can see now.
Okay. Um, Hello, good afternoon, good evening, good morning, wherever you are. Thank you for joining our Zoom academic meeting today. And today's meeting is on surgical management of vesicoretic reflux by Dr. Rasik Shah. Um, to introduce Dr. Shah, our association goes as far back as I think about 1988-89, when I was training in pediatric surgery in Mumbai, and Dr. Shah was a rotating registrar from general surgery. And I am honest enough to say that Dr. Shah's surgical skills were far better than even my skills at that time. Currently, Dr. Shah is head of Department of Surgery at the SRCC Children's Hospital in South Mumbai. He has been real pioneer in minimal access pediatric surgery and also in pediatric cancer surgery and pediatric urology. And I know Dr. Shah went and did a 3-year fellowship in the States. And after he came back, he's the one who really started laparoscopic and thoracoscopic surgery in children in India. And he has taken it to far greater heights. Few brief achievements for Dr. Shah. He was first in the Mumbai or Bombay University in the exit examination. He was also awarded a special medal for that. He has been the past president and honorary secretary of the Indian Association of Pediatric Surgeons and also of the Pediatric Endoscopic Society, which is part of the Indian Association of Pediatric Surgeons. He has given many guest lectures. He has written articles in peer-reviewed journals, and he has had presentations, and he has participated as faculty in many international and national conferences. I think more than all the above, his real achievements in the field of pediatric endoscopic surgery are that he started an institute of medical and minimal access surgery training in Mumbai, and it is called as CMAST, and he has been the course director of that course in minimal invasive surgery. He also has a dedicated YouTube channel for pediatric minimal access surgery, and he has a United States patent on the laparoscopic device. So, Rasik, we are really very glad and privileged to have you as our guest speaker today. So, please give us your thoughts, your ideas, and share your knowledge about surgical management, including endoscopic management of vesicoretic reflux.
Thank you, Milind, for your kind words. And only correction is the institute was started by Dr. Udwadia, and I take care of pediatric courses as a director. So when Milind told me, I thought what needs to be presented, and then maybe I decided to present on vasecoscopic ureteral reimplant, but then modified the talk to surgical management of VUR because it is directed towards the trainee or students. Of course, some of the things will be useful to everybody, whoever attends. So we will go through it, and I will try and complete it in next 40 minutes or so. I have cut down a lot of information to complete in that period of 40-45 minutes. Let's see how well we can do. So we are basically going to just go through some general slides and then surgical part of VUR. So the VUR or vesico-ureteral reflux can be divided into primary and secondary. In primary, there is a deficiency of UV junction. Bladder and ureter are normal in general, and reflux occurs despite of adequacy of low pressure urine storage profile in the bladder and that is basically because the diameter of the ureter and the tunnel is not maintaining that 5:1. So this is a normal insertion. This is not normal, it is suboptimal, and this is inadequate. So in this patient, there will be definitely vesico-ureteric reflux. Here it may be there, may not be there. Now, only disclaimer will be all these photographs are basically downloaded from internet just for the teaching purpose. The secondary VUR will be something where the uretero-vesical junction is being overwhelmed, and usually it is because of the bladder dysfunction, which can be either congenital, acquired, or behavioral in its origin. And as you can imagine, it can be anything: PURs, ureterocele, ureteral duplication, neurogenic bladder, dysfunctional voiding, and even the plain constipation can give rise to VUR. So a lot of kids will have underlying constipation which needs to be treated, and the urinary symptoms can subside, including vesico-ureteric reflux. Then the grading is very important to plan the management. So this is the grading on micturating cystourethrogram. Grade 1 and 2, we will call it as a mild, where there is a non-dilated or reflux is in non-dilated lower ureter, or up to pelvis and calyces, but there is no dilatation. Once you see the dilatation, it becomes moderate. And once you see a lot of tortuosity with blunting of calyces, it becomes severe. Then MCUG is very important because it will tell you a lot of information, and one has to, I attend all my MCUs as far as possible, because if it is not done properly, or if our radiologists not look what I want to look, there is a lot of confusion. So either I attend or one of my junior will attend, and we will have all the information. So all this is standard. I don't think I need to tell in general anything about that. But what I want to tell you or remember is the delayed or post-void film is very important, because if there is a contrast which is remaining into the ureter or PC system, it means there may be underlying even VUJ obstruction. And if VUJ obstruction is there, then this patient will need surgery. It will not get over just with the medical treatment. Now, uroflowmetry and urodynamic studies are important in some of the patients. And just even if you can uroflowmetry, it will, if it is normal, then by and large, you can rule out any underlying neurogenic bladder. Upper tract assessment with sonography and DMSA is again important, and we must do it before the surgery, because that is the way you can follow up after the surgery, whether the function has improved, deteriorated, or is static. Now, spontaneous resolution is very high in low-grade reflux, grade 1 and 2. And in such a patient, generally, we don't want to treat it surgically, at least to begin with. At the same time, grade 5, grade 4, the resolution, the natural or spontaneous resolution is very low. And in them, one may consider surgery primarily. This is what I will like to say. In grade 3, it will be equivocal. So grade 1 and 2, you don't want to treat primarily surgically unless it is indicated. So continuing with the management, as I told you, spontaneous resolution of reflux is common. High-grade reflux is less likely to resolve spontaneously. The success rate with surgical correction is very high. Sterile reflux is benign by and large. Watchful waiting while sterility through the judicious use of single daily low-dose antimicrobial prophylaxis is important. It can resolve at least mild grade and some of the severe grade as well. Often antibiotics are given once per day, preferably at night. Night dosing allows antibiotic concentration in the bladder urine over the longest period. Breakthrough febrile urinary infection or pyelonephritis while on antibiotic prophylaxis are generally considered as an indication for termination of watchful waiting and correcting the reflux by surgical intervention. Continuing with that, uroprophylaxis, in first 8 weeks, we will give either amoxicillin or cefixime, and later on trimethoprim, sulfamethoxazole, or nitrofurantoin, 1/4 of the dose, preferably at night. And you continue till the reflux is subsided. And newer guidelines says that you can discontinue in a milder grade after 1 year, but that will be individual choice. This is also a precise time for reinforcing lifelong adaptation of good toileting and bladder behaviors. Now, surgical management, when it is indicated. So we will go through the absolute indication. As I told you earlier, if there is breakthrough urinary tract infection, failure of medical management, which are one of the same, if patient is non-compliant in taking the medicine or uroprophylaxis, if there is persistent of reflux with prolonged medical management, progressive deterioration of renal function, you want to fix it. Ureteral obstruction associated with VUR, which I told you in MCU how you can make out. Refluxing ureter opening into the diverticulum, the reflux is less likely to subside, so better to fix it. And if you do cystoscopy and if you observe there is a gall hole orifice, then better to fix it. The relative indication would be presence of massive reflux like grade 4 and 5. If the VUR is associated with paraureteral diverticulum, actually this is an indication, so it is not relative, but it is absolute. In girls whose reflux persists after they have reached the puberty, and parental preference. Some parents may say better to fix it. They may not want to have particularly when we have endoscopic treatment available, some of the parents may prefer to fix it rather than giving uroprophylaxis and worrying about getting the urinary infection. So what are the surgical options today? So we can do the procedure through the bladder, either open or vasicoscopic. We can do trans-trigonal COHEN'S or POLITANO LEADBETTER techniques. So if you are doing this through the bladder, then these are the two common surgeries which are being performed today. COHEN'S or POLITANO LEADBETTER. We will just go through the important steps of all this procedure. Then it can be done extravesical, and it can be done either using open technique or laparoscopic technique. The last is sting or subureteral, transurethral injection. Now, even this procedure can be done robotically. Both transvesical and extravesical ureter implant can be done robotically. And we will not go into the robotics much because it's not easily available everywhere. But if it is available, it can be done because suturing is easier. Only issues are the port size are much larger than what we do with laparoscopy. The principles of surgical corrections will include primarily you have to exclude that there is no underlying secondary cause of the VUR, because if there is a secondary cause and if we don't manage that, then even after surgical correction, the reflux can recur. Then adequate ureteral mobilization without tension, protection of ureteral blood supply. This is most important. If we damage the blood supply, then it can lead to ischemia, it can lead to stricture, and something which had reflux, it can get obstructed segment and the function of the kidney can go down. There can be problems because of infection, a lot of things. So protection of the ureteral blood supply, like all other procedures, is very important in surgery for VUR. Then generous submucosal tunnel should be fashioned. So depending upon the size of the ureter, what you are going to pull down through the tunnel, you have to make wide tunnel, and you have to always make sure that the tunnel is submucosal, means you don't want to go part of that through the muscle because that can create a problem. So generous submucosal tunnel is important. Attention should be directed to prevent angulation and twisting. Bladder tissues must be handled gently. Attention to muscular backing of ureter to achieve effective anti-reflux mechanism. Creation of submucosal tunnel that satisfy 5:1 ratio of length. Even if you can get 3:1, most of the time there is no problem. Continuing with the principles, for any good surgery, you have for any surgeries to have good results is very important to have good visualization. So if you are going to do it endoscopically, you have to have a good camera to do the procedure with good results. Closure of original ureteric hiatus on the medial side. We will go through the videos, so some of the points will be more it will be appreciated well. Sometimes we take incision on the superior lateral aspect of the hiatus. By doing that, we shift the entry of the ureter laterally, and we can have little longer submucosal tunnel. Good vascularity of ureter is important. So, and then it has to be done using sharp dissection. There is no role of doing the dissection bluntly. You can use diathermy or scissors. But if you use diathermy, you have to be careful that you don't damage the blood supply. If you use scissors, there may be little bleeding, which you can control using diathermy once you see the bleeder. Adequate spatulation of the end of the ureter, adequate fixation of the ureter. When I say adequate fixation, we take at least one suture of the bladder muscle with the end of the ureter. So the ureter don't go back into the tunnel. Mucosal to mucosal suturing. Each suture is important, and you have to be, this is particularly when you are doing it vasicoscopically, then you have to make sure that the sutures are placed well. And insertion of DJ stent and Foley's catheter. Now, in DJ stent and Foley's catheter, now if you are doing vasicoscopically, you can remove the Foley's catheter in 36 to 48 hours. DJ stent generally we take out after 3-4 weeks. Now, sometimes when we do this procedure, what we do is tie DJ stent with the Foley's catheter. If we are very happy with whatever has been done, then the stents will come out along with the Foley's catheter after 5 days. So in some of the patients, we have done that without any problem. Occasionally, you can, even if you do open, you can remove the Foley's catheter after 3-4 days without any problem. We used to keep for 5 days, but in some of the patients, we are removing the Foley's catheter early today. Now, what is COHEN'S trans-trigonal ureteral reimplant? So I'll just go through the steps. Generally, everybody does through phalangeal incision. Then you open the bladder vertically between the stay suture. Suture at the inferior end of the vertical bladder incision. So accidentally, the incision do not go into the bladder neck area, because if it goes, then it will bleed, and then it becomes very difficult to close that. Placement of mop and ring retractor to stage the trigone, mobilization of ureter by sharp incision, safeguarding the peritoneum and vas in a male child. So once you start dissecting the lower ureter, you have to make sure that you don't damage the peritoneum or vas. Peritoneum meaning the intra-abdominal structures. Closure of the hiatus, as we discussed earlier, creation of the tunnel, and all these steps as we have discussed. So COHEN'S is basically what you do is mobilize the ureter, create a tunnel. Generally, it goes to the opposite ureteric opening so that you have adequate tunnel. And then you suture this mucosa to mucosa, and one suture, as I told you, will be full thickness. Before you do that, you have to make sure that you close the hiatus on the medial side, and then you complete the procedure. Now, what is POLITANO LEADBETTER technique? So what you do in that is, apart from dissecting the ureter, closing the hiatus like this, what you do is you go full thickness bladder outside from the ureteric hiatus, and you make the incision on the higher side on the muscles and the mucosa. And once you do that, you like this, you go full thickness outside, take out the ureter from this opening, and then you create the tunnel and pull it out like this. So here, if you see, this is the ureter which is entering the bladder from here, and then you will do the anastomosis here. The terminal part of the ureter is discarded in most of the patient with VUR as well as in an obstructive megaureter, and then you spatulate. So because any circular cut is going to heal with narrowing. So once you spatulate, it is large so that even if it has to contract, it will not contract, creating an obstruction. Now, the Politano LEADBETTER technique can be done just transvasically, or it can be done using combined transvasical and extravasical approach. Yeah, it can be done even extravasically. So, like all other principles remains the same. If you are going to do extravasical reimplant, then what we do is fill up the bladder partially. You again, we make the incision. If it is unilateral, you make incision on the one side, lower abdominal. If it is bilateral, extravasical, generally we don't prefer. If it is unilateral, then only we will do extravasical ureteral reimplant. Uh, so you partially fill the bladder, and then you do careful division of the muscles like this, and then you do suturing. Now this is if you have to discard the lower part of the ureter. If you don't have to discard, then you can just make the incision like this, and then you can suture the muscles on the top of the ureter. So this is the extravasical reimplant. We'll see later small video on both. Now, many times there is a dilated ureter. Now, in dilated ureter, what you are supposed to do? There is something like Hagen-Poiseuille's law, where what it says is there is tenfold increase in the flow for every 1 millimeter increase in the diameter of a tube. Now, ureteral dilatation may be the mechanism for maintaining a low intraluminal pressure. It has demonstrated that the muscle cell integrity is adequate in most of the uninfected and massively dilated ureter. However, since the ureter lumen is incompletely obliterated by contraction, the peristalsis is ineffective. So if it is a dilated ureter, the peristalsis is going to be ineffective, and that is the reason we need to do some kind of tapering in them. The another thing is which can be asked in exam is Laplace's equation. It is what pressure is equal to tension divided by radius. So if the diameter is more, then the pressure generated is low. So moment you decrease the diameter, the pressure generated will be high, and it will help in propelling the urine out. So because of this, in a dilated ureter, we need to do tapering adequately so that the urinary flow can be maintained well. Now, one can decide whether you just want to do lower ureter or you want to do entire ureter, and that will depend upon how bad is the ureter dilatation and tortuosity. So the rationale of ureteral remodeling is if the mega ureter or ureter is 2 centimeter wide, we cannot have 8 centimeter tunnel, and that is the reason why we need to taper. So any ureter which is more than 7 millimeter in a collapse diameter needs some kind of tapering, because we can have maximum 3 to 4 centimeter of length in a small child. And once you do tapering, there will be coaptation of the wall and the urine will propel. So this is just a diagrammatic representation. If it is a ureter is normal size, then this is how there will be coaptation. If it is large size, then the coaptation does not occur and there is not effective propellation of the urine. Now tapering can be non-excisional using Kelly-Ski's ureteral folding or starts plication, or it can be excisional, lower ureter or entire ureter needs to be judged on how bad is the dilatation and tortuosity. So this is starts plication. You can see that is the standard way of plication, but it is important on all this procedure that you maintain the blood supply. This is the Kalinski's ureteral folding. You can see this is how you put the sutures. You put some kind of stent inside so that you don't obliterate the lumen. Once you have this, then you fold it onto it so that the size is decreased. So there is a propulsion of urine. Now, if you are doing it vasicoscopically, then it's a difficult operation, but some people can still do it. I've never done that. You can deliver the ureter either from the port side, or in girls, you can deliver from the urethra also, and you can do tapering, push it back, and then do the rest of the procedure. Or you can fix the ureter near the bladder neck and then carry out the tapering. But this is highly demanding operation. If you are going to do it vasicoscopically, it is demanding even in open surgery. Now, the another is excision. So you can excise something like this and suture it. Only thing, when you do this, there is a small chance there can be some kind of leakage and other things. So you have to be ready, as well as you can damage the blood supply. So you have to maintain that the blood supply of the ureter is maintained when you are doing this. Usually the blood supply comes from the medial side, so that tapering can be done on the lateral aspect. Now, sometimes you will end up with the loss of ureter and you don't have adequate ureter to do reimplantation or gain the tunnel. Then what do you do? So you have few options. Particularly loss of ureter may happen if somebody has done a low lying ureterostomy and the distal part of the ureter is not adequate. I mean, you can't do suturing or ureterostomy and then do reimplant. So in some of the condition, you will end up doing something more than just a standard ureteric surgery or ureteric reimplant. So what are the options? We have psoas hitch. In psoas hitch, what you do is you fix the bladder at higher level. Normally, bladder will be like this. So you take the bladder up, suture it, and then you do ureteric anastomosis with the bladder so that you have adequate tunnel, as well as you can do the anastomosis. So that is the psoas hitch. Second option is Boari flap of the bladder. We will just see in next slide. You can do transureterostomy, or you can use appendix on the right side or Montis. So appendix or Montis procedure. On left side, you can use Montis procedure. So what is Boari's flap? So in Boari's flap, you make an incision, something like that, and you open up. And once you open up, you fix the bladder with the psoas, and then you close it vertically. So this is, of course, you will have to do this extravesical as well as transvesical. Both the things you will end up doing in such a patient, but you can do anastomosis like this. So this is Boari flap with psoas hitch. Then on the right side, you can use the appendix. So that's the appendix, which is bridging the gap from the ureter to the bladder. On the left side, you can use the Montis procedure. So use the small bowel, detubularize it, and then suture bowel to bowel, and then retubularize it. And then last is, as I told you, TEU. So wherever the ureter is not there, you anastomose with the upper opposite side ureter, and you may be done if there is no reflux on the other side. Sometimes when the bladder is small and both side reflux is bad, one can do TEU so that you have to anastomose only one ureter, or you have to reimplant only one ureter, and it may be easier than reimplanting both the ureters. Ureteral preservation of blood supply. So as I told you, medial mesoureter with its vascular. So you have to make sure that you are outside the adventitia and you don't damage any blood supply. But particularly there are perforating end arteries, and you make sure that when the ureter is tortuous, then sometimes the blood supply also is tortuous, and you may have to spiral while doing tapering. Of course, I never had any chance to do this, but when you have very bad ureter, you may end up doing that. Now, vasicoscopic ureteral reimplant, it's a very difficult operation, needs lot of experience in suturing in a small space and patience. Results are gratifying. Bladder is not opened, so the involuntary bladder contractions are very low and patients are very happy. So we will see a small video. I had earlier slides of explaining each step, but we will just go through the video. So that's the ureteric opening. That's the left side ureteric opening. So you do cystoscopy before doing vasicoscopic ureteric reimplant. Then there are two ways you can put the ports inside the bladder. So what many of us in India do is put a ureteric, not ureteric, but urethral dilator from the urethra and push it against the abdominal wall. And once you feel that, you make an incision on that. The first port or camera port is about 2 centimeter or 1.5 centimeter below the umbilicus in the midline. We make a horizontal cut and then take the bladder wall, suture it with the skin, put the 5 millimeter port for the camera. And similarly, you will put 3 millimeter port on the either side on the lower part. And then you do depending upon the bladder size, which may be anywhere between 100 to 200 ml capacity, you will end up doing this. The second way is by doing cystoscopy, and under cystoscopy guidance, you put the ports. We will not go into the details of this, but if anybody is interested, I can explain them later on. Whenever you are interested, let me know. Yeah, so we will continue. Then you put the ureteric catheter through the urethra. It has come, and you put the either feeding tube or ureteric catheter. Now this is a suture. You don't need to fix with the catheter. You just, so this is used basically for retraction. Then you can use a monopolar diathermy to mark your incision, and then you can cut with the scissors or you can cut with the hook. Both are fine, but you have to be, now this is the lower part, so actually you are not worried about damaging the blood supply in this area, because you are going to, at the end, you are going to discard it. So using diathermy and scissors, you will continue dissection. You can see these are the muscles, detrusor muscles. Once you have dissected off the detrusor muscles, you have to make sure in a male child that vas and peritoneum, you have to be careful. And this is, we are dissecting. This was the part which was relatively narrow. You can see now this is the dilated ureter which is coming up. So we are going to excise this much of the ureter, whatever is dirty, devascularize also. And this is relatively dilated ureter. So when you assess the MCU film, you always see what is the tortuosity and dilatation. If there is adequate tortuosity, you will have adequate length. Now here I could not put any French infant feeding tube. So this is a 3 French infant ureteric catheter was placed. Sometimes I make the incision on the lateral aspect. It gives me added length for making a tunnel. So of course there the ureter was quite large. So just to make sure there is no constriction at the hiatus, I made that cut. Then you create the tunnel. And here again, if you are going to do vasicoscopically, one trick will be, after making a tunnel with the scissors, I will put a bowel grasper, which is 3 millimeter in size. But when it opens widely. So you have generous submucosal tunnel. So that is a bowel grasper which was placed to make sure that the the tunnel is adequate in size. And then from the left side, you put the, you pull the ureter. Now, usually when you are pulling like this, the chances of it being tortuous, getting kinked, are relatively less. And then you fix it, spatulate, and then fix it. Of course, this was dilated, so it was not to be not much of speculation is required. You can see the tunnel was right from there to there. So it is at least about 3.5 centimeter in size. Now this suture I will generally take deep with the muscles so that it is gets fixed and the chances of retraction are less. The opposite side ureteric catheter, it is important so that you don't damage the opposite ureter. This was unilateral reflux. Then we put a DJ stent. Another important thing is whenever I do vasicoscopic surgery, I will straighten the needle. Straightening is important so that you can put the needle in as well as you can take it out. And you want to take out as soon as that suture length is inadequate, because if you don't take it out, it comes in your way. So if it is straightened, you can take it out through 3 mm port. In all other surgeries, I don't straighten the needle. I just use the curve. It helps me. And then you do mucosa to mucosa suturing. Some of the rents, if you leave behind, there is no worry. It heals very fast. Within a couple of days, the mucosa will heal. So we will take it out through either 3 mm port, or we will push it in 5 mm port and take it out. At the end, you put the Foley's catheter, and then you remove. This is 3 mm port which has been removed, or yeah. And you have the sutures. You can see that suture is there, so you stitch it up outside. So this was vasicoscopic ureteric reimplant. I'll show you short video of the extravesical ureteral reimplant. We don't do many extravesical ureteral reimplant. The only place where I have done is in an obstructive megaureter, where of course this was in vasicoureteric reflux. On cystoscopy, you can see a large diverticulum, and we could not see the ureteric orifice, and we went ahead and did extravesical ureteral reimplant. But if I have done ureterostomy for obstructive megaureter in a 1-month-old, 2-month-old child, then I'll do extravesical reimplant in that child. So you can see that the ureter is more or less normal in size. That's a large diverticulum. There's the stay suture which has been taken on diverticulum to dissect it. So that's the dissection will be going on. That's the vas. You have to be careful of the vas. You don't want to damage the vas. So the diverticulum is being dissected. Sorry. So diverticulum is being dissected. Then it is excised from the uretrovesical junction. And once you do that, then either you can anastomose the normal ureter there, but what we decided to close that hiatus and do the reimplant at higher level, so that I don't have to disturb the vas. It is important to have adequate tunnel. Where you make it is not important. But if it is near trigone, it is always better. So this is the, sorry. Yeah, so we are making the incision where our extramucosal tunnel will be. So that's the tunnel which has been created. If you open the mucosa, nothing to worry about it. As I told you, it heals very fast, and here the ureter will be right there. So ureter is spatulated now. Then we have placed the DJ stent, and then you suture the ureter with the opening in the bladder. So 4 or 5 sutures are adequate to do the anastomosis. These are difficult operations. The robotically it is relatively easier. So all these kind of surgeries, if you have access to the robot, it will be good. So that is the anastomosis which is being done. And then we will suture the ureter in a submucosal tunnel. So this suture is very important. If you see, Yeah, you have to go behind the ureter, come back and suture it. Yeah. And you have to make sure there is adequate submucosal tunnel so that there is no obstruction to the ureter. So this looks narrow, but it was adequate. So the remaining sutures are taken now, so of the muscles with muscles. So that is the tunnel, which will be at least about 4 times the diameter of the ureter. Then you can put the Foley's and come out. If you are worried, you can put the drain in the peritoneum, which you can take out after 48 hours if there is not much of the drainage. So that is extravesical ureteric reimplant. Follow-up discharge on PEM or uroprophylaxis. You monitor BP, renal function, urine analysis, do sonography, urine culture as and when indicated. Generally, VCUG you can do either after 3 months or 1 year, but you can discontinue the uroprophylaxis after 3 months and DMSA after 1 year, but it's not mandatory. The complications of this procedure will be persistent reflux, usually resolves by 1 year on repeat cystography. So today we do repeat MCU only after 1 year, and we discontinue prophylaxis after 3 months. Contralateral reflux can occur in 5 to 11% of the cases, and usually it is mild grade and seen with high grade VUR and duplex system, and no difference amongst the any procedure, whatever you do it. Prophylactic reimplantation, most of the people don't do it. Obstruction can occur due to edema, clot, or twisting or kinking of ureter. If any patient has very severe hydroureteral nephrosis on sonography or urinary reflux, then one may end up doing a redo procedure. Then something about subureteral, transurethral injection or sting procedure. So injection of biocompatible bulking agent beneath the transvesical portion of ureter in a submucosal tunnel. It elevates the intravesical ureter, narrowing the lumen. It prevents regurgitation or reflux and allows the integrate flow. The advantage is it's less morbid, no mortality, no scars. Disadvantage is cost and lower success rate compared to surgery in high grade reflux. So basically, means in grade 1, 2, most of us don't do it, and in high grade it does not work. So there is a limited use of sting procedure, though those who are doing routinely, they will say that even in higher grade, the results are good, but that is not been seen widely. What they do, I'll show you a short video, and then the new technique, what they are proposing with the good results, we'll just discuss that and we'll end the talk. So that's the ureteric opening. Now on the needle, if you know, there are 2 points. One is the circular marking. So that tells you that you know how much needle is inside, and there is a square. Square shows you where the bevel is lying. So that's the square which you need to remember, and there's the circle. So these are the 2 important things. And at the end of the injection, you want to have something like that, mount like that. So that is working. Of course, here there was some trabeculations also. So of course, there was no other reason to have this. So we had injected, and that kid is doing all right. Hydrodistension technique or HIT technique, which is being used today. So what is that? Hydrodistension is of ureteral orifice and distal ureter, permits visualization of the intraureteral submucosal injection site and assessment of the degree of ureteral coaptation. So H0 to H3. H0 denotes absence of ureteral dilatation. H1 indicates only of orifice. H2 allows visualization of intramureteral ureter. A3 allows visualization of extramural ureter. And what is being proposed is double hit technique, means you want to inject at two places. Um, so first is you go inside the ureter and then inject, and then you come out and inject again. And with that, the results are much better. So thank you for the opportunity. I have a lot of videos which are there on my YouTube channel, which you can go and see anytime. There are videos of even vasicoscopic ureteral reimplant in, I think, bilateral as well as duplex, as well as obstructed mega ureter. As we were discussing earlier, we have um, we have courses which go around the year at IMUS. It used to be known as CMUS, Center of Excellence for Minimal Access Surgical Training. The name is changed to IMUS because the ownership has changed from Karl Storz to Sun Pharma. So there we have 4 types of courses. One is basic or intensive, which is scheduled 1st, 2nd, 3rd of June. Then one we have advanced GI, then we have advanced pediatric urology and endourology, and then we have thoracoscopy course also, thoracoscopy bronchoscopy course. In addition, we have even 1 month fellowship, which is intensive training for 1 month in minimal access surgery. I think we already had 8 or 9 fellows over pre-COVID time. We had just started 1 year before the COVID. And in that 1 year, I think nine students for training, they came, they spent 1 month at CMUS and they came to the OT with us. If there are no surgeries in operating room, then they will go and practice at IMUS. And there everything is covered, all 4 courses, what we say. And there are animal lab is, it used to be once, which has been increased to twice. So that is about the CMUS. I mean, you can go to the IMUS website and you can register for the courses and find out if you are interested in anything particular. You can write to me also, and I will help you and guide you wherever possible. So if there are any questions, I'll be happy to answer. Mirin, you can take over.
Rasik, thank you very much. That was really very nice teaching for the juniors, for the registrars, and also very nice overview of videoscopic and laparoscopic techniques for these operations. So thank you. That was really excellent. I see there is only one question from George Knock. We'd like to find out if there is any explanation for resolution of type 1 to 3 reflux as the child grows older. So if you can answer that.
The submucosal length increases as the child is growing, bladder is growing, and the submucosal tunnel, which may be small or narrow, the lengthwise it will grow, and the reflux will subside.
Okay, thank you.
And that will happen up to the age of 7 years. If it does not subside by 7 years, then it is unlikely to subside later on.
Yes, thank you, Rasik. Rasik,
Yeah.
we have Professor Martin Fanikirk, who is a
Yeah.
personal friend of mine, and he doesn't do urology, but he's probably the most experienced pediatric laparoscopic surgeon in country. He practices in Pretoria. And interesting thing
Okay.
is, in the University of Pretoria, they have recently started a very nice laparoscopic training course. So I would like Professor Martin to make some comments, and maybe later on I can introduce the two of you to each other, and you can then consider collaboration or sharing of knowledge and skills. So Martin, you will just need to unmute yourself.
Danesh had one
Don't know
question.
whether I don't know whether
Yeah.
Professor Fanikirk is here. He may have left, but I will get him touch with you. There's one more question, Rasik. Is it necessary to disconnect ureter in all cases of extravesical reimplants? It's from Dr.
No,
Dinesh
it is
Desai.
No, it is not necessary. In fact, I did mention that it is not necessary to disconnect. And if you don't disconnect, you make sure that you make the incision around the ureter so that you can have tunnel. I mean, you can suture the muscles right up to UV junction. So you make a cut right up to UV junction, and then you go on the sides. Deepen the deepen through the muscle in a submucosal area and then suture it back. So it is not necessary.
Okay, thank you, Rasik. I will ask our consultant, senior consultant pediatric surgeon, Dr. Yashoda Manikchand, to give her comments or maybe ask any question if she has to Dr. Shah. Yashoda?
I thank you, Prof. And thank you, Dr. Shah. That was a really excellent presentation. I really enjoyed it, especially the videos. And maybe one day we can do basic vesicoscopic surgery here. I don't think we're there yet, but I'd love to learn about it. I just have one question. We see a lot of Eagle-Barrett syndrome kids with mega ureters and quite severe reflux. So is there any operation you would offer them? Which
syndrome?
Eagle-Barrett syndrome?
The
prune
belly syndrome.
Prune belly syndrome, yes. Okay. So in prune belly syndrome, generally, I mean, the bladder is also problem. So you need to, I mean, if they have problem, yes, one may do it. Personally, I don't have much experience of prune belly. We don't see many in India.
Okay.
Is in last 25 years, almost 23 years of practice, I am yet to see a prune belly syndrome. Not very common. So, but I mean, if it is giving rise to problem, yes, we will have to do a lot of things for them, starting from bladder to ureteric remodeling as well as abdominal remodeling.
Okay, thank you. Yeah, we do see it quite commonly here. Actually, the most.
How you manage? You tell us. I will learn from you.
That's quite interesting, Yashoda, isn't it? That he hasn't seen one, that we see quite a few of them. Yeah.
Yeah, very interesting, because our most severe reflux cases are actually our Eagle-Barrett syndrome cases, and we kind of sit on them for quite a while.
Yes.
I haven't offered surgery to any one of our patients, so I was hoping for some guidance, but yeah, and the mega ureter is all the way up to the power. So it's yeah, I don't know whether it's advantageous to taper the entire ureter and reimplant it.
I think if it is badly dilated tortuous ureter, then we probably need to do remodeling of the entire ureter.
Yeah.
Part of that will not work. If it is indicated, it should be entire.
Yeah. Okay, thank you so much. And hopefully I will come visit you at CMAST at some point.
Sure. Most welcome. Spend the entire month, then you will learn a lot.
Okay, thank you.
Yashoda, I think we will have to facilitate bilateral exchange, that you people one at a time go and spend time with him in Mumbai once this COVID is under even more control. And I think it is time for us to invite him to South Africa, and then maybe even participate in some training in Pretoria or even in Maritzburg, and obviously visit East London. So we will work on that through our trust.
Yes, that's a good idea, Prof.
And I just want to read a comment by Dr. Vishal Sawant, that says abdominoplasty is also required in prune belly syndrome. It may be better to do an open up repair, and lower ureters are pathological and need excision. So I think we will agree with that observation from Dr. Sawant. I see. Yeah, you would agree with that, Rasik?
Yeah, completely. Yes. I mean, it is a tortuous ureter, so you need to resect the lower part so that the ureter becomes straight. At the same time, you do excisional tapering, so that the lumen also decreases. But they are means these are the surgeries which one has to be very careful while performing. They are not easy operations.
Yes, of course. Dr. Majola, is Dr. Majola still here? Dr. Majola is a consultant pediatric surgeon in another bigger city in our province, Port Elizabeth, and he has special interest in urology. So, Dr. Majola, are
Yeah.
you still around?
Hi, Prof. Thank you, Dr. Shah, for the great talk. Yeah, I missed out on an opportunity as well to come to learn from you because of COVID. So I'm still trying to get across to come and visit you. I think we have spoken before to come and spend some time with you. But yeah, I don't have any particular questions because your talk just covered a wide variety and anything that I was sort of wanting to know more. Thank you.
Thank you.
Rasik, I would now
Yeah.
thank you once again for participating, and I think people will probably contact you after this talk, because I see
Yeah.
at one stage we had about 60 participants, which is great. So I would just
Yeah.
request you to maybe summarize and just give us a take-home message from your talk.
Take-home messages will be not all reflux needs surgical fixation, but when it is indicated, one should not delay it. What I have seen, at least in India, a lot of nephrologists, pediatric nephrologists, pediatrician, they avoid doing micturating cystourethrogram until the child has multiple urinary infections. So we don't like that. And when it is indicated, go ahead and fix it. If you have adequate experience, then vasectomy, otherwise even open surgeries are fine, because it's small financial incision, they do all right. Except the advantage of vasectomy is you are not opening the bladder, so the contractions are less, pain is less, and you can discharge the patient in 2-3 days time. But they are high demanding operation. In a milder reflux, one can consider doing sting operation, and you can have good results of that. In a grade 4-5 reflux, generally we don't like to do sting procedure. We will go ahead and fix it. And these are when you, even if you do it open, it is important to make sure that you adhere to standard guidelines of doing all this mobilization with preservation of the blood supply and suturing, speculation. Then most of them, the results are gratifying. They will be more than 98% of them will do well. Yeah.
Okay, Rasik, no, thank you very much. That was really wonderful seeing you again and learning from you. So we'll keep in touch. Thank you again, and I will make this video. I'll once it is recorded, I'll share the link with you
Thanks.
so that you can share it with your colleagues also. And we hope to have Dr. Ketan Parikh, who is also a very senior pediatric endoscopic surgeon from Mumbai, also one of my ex-colleagues. We are hoping that he will be able to give us a talk on the second Tuesday of June on some of the laparoscopic surgeries like splenectomy and nephrectomy and colectomy. Thank you, Rasik. You have a good evening. Bye-bye.
Thank you. Thank you.